Welcome to Grand Rounds for October 2023. Today we have with us two of our providers who are going to talk to us, one about burnout and residency and the other about lifting style and injury risk. So first we have Dr. Megan Lokay. Dr. Lokay received a bachelor's and master's degree in exercise science from East Stroudsburg University and a doctor of physical therapy from DeSales University. She is currently a resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. Through experiences of her friends and family, as well as her own life, Dr. Lokay has developed an interest in the impacts of burnout and stress in the work and residency environment, and has also developed an increased research agenda of how to deal with both stress and burnout to help her friends and family, as well as herself. In her free time, Dr. Lokay enjoys spending time outside fishing, hiking, golfing, and camping, as well as going on adventures with her dog, Lucy. Next, we have Dr. Lokay McEliece. Dr. McEliece obtained a bachelor's degree in health and exercise physiology and a minor in human performance assessment from Ursinus College. He earned his Doctor of Physical Therapy from DeSales University. Currently, he serves as chief resident in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. And Dr. McEliece is a certified strength and conditioning specialist who worked with clients to improve their strength and function prior to his doctoral education. He's also a former collegiate athlete, and he has firsthand experience participating in strength sports and coaching a variety of athletes. He has a love of movement and exercise, which he has carried with him from his undergraduate career. He integrates strength and conditioning principles into his treatment methods, enabling his clients and patients to achieve their goals and reduce fear associated with movement. So as a few reminders, please make sure you sign in using the code on the left or the QR code on the right. And after the program is completed, make sure you complete the quiz as well as the course evaluation. Both are mandatory in order to get your CE or CME, whichever is appropriate for you. If you have any questions, please do reach out. And so I just want to go over our CME credit information. This is our statement of need, and the target audience is for all providers. This is our designation statement, and neither the planners nor the presenters have anything to disclose. So first, let me introduce Dr. Lokay, who's going to talk to us about stress and burnout in residency.
Thank you, Dr. Karahoff, for the introduction. As you said, I'm Megan, and I will be talking about stress and burnout in a residency program. So the learning objectives for today. Okay. So the learning objectives for today are discussing the benefits of completing a residency program, discussing stress and work-life balance while doing so, comparing and contrasting physical therapy residents with other medical residency programs as well, and then finally discussing strategies to help deal with stress and burnout. So first of all, why do a physical therapy residency? The important parts would be to develop more efficient and effective care so that we're treating our patients with the best options that they have. There is weekly one-on-one mentoring, so you are paired with a senior clinician every single week. And during that time, you get to review patients, go through evals, and just bounce ideas back and forth so that you're also providing your patients with the best care. All of this helps to improve your confidence as a clinician. And then finally, grouping everything together basically helps you better enhance your ability to deliver high-quality, patient-centered care, which at the end of the day, that's what it's all about. Doing a physical therapy residency also helps with your employers' and colleagues' perception of you. So when it comes to employers' perception, they view residents as having more competence, more professional, higher maturities, and higher levels of autonomy. There was a positive influence on clinical skills and expertise in the clinic itself. And then finally, they viewed residents as having better leadership, communication, and patient outcomes. So basically, if you combine all of that together, employers perceived those who graduated from a residency or fellowship to be at a higher level sometimes than those that did not. Going along with this, there was an article in 2021 by Shepard et al. That looked at traits and attributes of successful physical therapy residents. There were 16 characteristics overall, but they looked at 5 specifically that they deemed absolutely essential, which were accountability, being a critical thinker, open to feedback, reflective, and teachable. Out of those 5, they said that the most important was being open to feedback. Other characteristics that they looked at were organization and grit, and all of these traits combined identified are consistent with something called the master adaptive learner. So this master adaptive learner is the type of learner that is equipped to problem solve, make informed decisions, and learn in a clinical practice environment. So combining all of this, I chose this picture because on the top of it, we all work to be successful in our own ways. But sometimes what we forget to realize ourselves, or what others don't realize, is there is a lot of behind the scenes work that. So sometimes all the things that you'll see on the bottom of the picture there, they can start to take over and become problematic, and that can lead to increased levels of stress and burnout and fatigue, but they're not necessarily noticed by everybody because you don't see it peeking out of the water like you do the mountain in the picture. So going into the definition of burnout, this is straight from the World Health Organization. Burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed, and it has 3 main dimensions. So those 3 main dimensions are a feeling of energy depletion or exhaustion, increased mental distance from one's jobs, or a feeling of negativism or cynicism related to the job, and reduced professional efficacy. Another study that was done looked at the 3 main components of burnout, and they categorized them into work-related factors, non-work-related factors, and personal factors. So the work-related factors were identified as poor work-life balance, concerns about patient care, work demands, seniority, poor career development, specialties, and poor work environment. Non-work-related factors were things such as financial or physical health, self-efficacy, and personal factors fell under non-work-related factors that can be considered personal life, work-life balance, post-grad training requirements, and they can also play a role. Out of all of these 3 components, they found the work-related factors to be the most contributing to burnout, but they all, to a degree, can play a role in burnout. There was 2 other factors that were also discussed, and they were emotional exhaustion and depersonalization. So emotional exhaustion was defined at emotionally overextending and worn out by one's work. Depersonalization was the feeling of detachment and impersonal response towards others. And in another study done by Ramio et al. In 2018 found that depersonalization may be the key driver in burnout. So I wanted to look at burnout not just in physical therapy residents, but just residents and physicians in general. So there was an article that stated that as high as 30% of physicians in teaching hospitals reported burnout. But when they looked at resident physicians specifically, it was as high as 75% in those residents. The burnout can lead to medical errors and attitudes towards patient care. There was a self-reported belief of diminished achievement as a part of burnout, and emotional exhaustion. As emotional exhaustion increased, performance decreased. There was a positive correlation that exists between punishment and improvement in scores as those with poor performance, and that's looking at the academic achievement bullet that I have. And repeated poor performance often results in negative consequences, which can sometimes lead to further burnout, mental exhaustion, and it kind of just creates this cyclical motion of burnout among physicians. The point that I made about poor performance leading to negative consequences is an important one, because sometimes it's not done super often, but sometimes it can be if you didn't do well in something, then you have to do additional work in that area, or you have to spend more time that you weren't additionally allotting to do it. So it's making you better. But the important part with that is also to realize that we are still humans. We still have a human aspect of everything. And at the end of the day, there are multiple things that go into what we have to do on a daily basis. So that demonstrates the importance of focusing on helping residents rather than punishing them for their lack of knowledge or difficulty in an area. Study done in 2019, and it looked at burnout data. There was a bunch of different specialties in this study, but I chose to look at 3 specific ones that seemed to vary the most. So there were 6 orthopedic physical therapy residents that they looked at, 16 ER faculty or physicians, and then 22 that worked in family medicine. So basically what they did was there was different scores that were calculated, a lower score, meaning there was no sign of burnout, and a higher score, meaning that there was very severe risk of burnout. So they looked at 3 specific areas, one being emotional exhaustion, depersonalization, and finally personal accomplishment. So when we look at the orthopedic physical therapy residents, they had the highest scores for personal accomplishments, which meant that they felt that they were dealing effectively with problems and having a positive influence on what they were doing on a daily basis. When we looked at the responses for the ER, they had high scores for personal accomplishments, but they also fell into the risk of burnout / borderline severe burnout when it came to the other 2 areas. And most interestingly, I found that when I looked at family medicine, they also ranked themselves high in personal accomplishments, but they fell into the severe risk of burnout for emotional exhaustion, and they were in the risk or severe risk of burnout for depersonalization. So this just goes to show that there is burnout widespread throughout different specialties, and it's an issue among multiple different people and different areas of care. The one thing that it can lead to is issues with patient care. So there can be issues with medical errors, attitudes towards patients, providing suboptimal patient care. We went back and we talked about the academic achievement in residency previously, and then overall just professionalism. So academic achievement in residency was previously mentioned, but to reiterate it, it's regarding repercussions from feeling behind amidst the overwhelming workload, and the overall stress of completing additional work. The lack of devotion to best practice principles can be viewed as failure to practice with integrity, honesty, and in the best interest of the patients. And overall, higher levels of burnout may also lead to being less likely to meet professional expectations, which can further put you down the rabbit hole. So it's not just a personal thing at that point when it starts seeping over into your work life. So one question that I had was, does it last? Is this a thing that happens right now and goes away, or does it last into the future? So a study that I alluded to earlier, the one by Ramio in 2018, they did a study called The Correlation of Stress in Residency with Future Stress and Burnout, and it was a 10-year prospective cohort study. Excuse me. They started with 142 residents, and then 10 years later, were also able to get responses from 82. So they initially looked at the Profile of Moods questionnaire, which is a 64-item psychometric instrument that measures mood states such as tension, depression, anger. They measured burnout using the 9-item abbreviated Maslow burnout inventory. From this study, they found a significant positive correlation between emotional distress as a resident and current emotional distress 10 years later. What they basically found from this study was, if they gave you the survey when you were a resident, all of those feelings for the most part seem to carry over 10 years later. So it's not something that just happens and goes away immediately. It can have long-lasting effects. The one part that I liked from the study was that they said that future wellness research should examine whether interventions during graduate medical education can have sustained effects later in physicians' careers, basically saying we need to do more longitudinal studies to see what we can do to affect this in the long run. So overall, we talked about burnout, talked about what it is, talked about how it can affect work life, personal life. So what can we do about it? So the concept on the left of your screen, it's the components of something called emotional intelligence. On the right side of the screen is a picture of a book that they actually handed us on our first day of orthopedic physical therapy residency. When it's talking about emotional intelligence, high levels of emotional intelligence may be proactive from developing burnout, as the people that possess those skills and have more effective coping strategies enable them to be better resilient and manage their stress better. So developing those emotional intelligence skills in physicians and training may help with that burnout down the road and also optimize their overall wellness. In that book that's on the right side of the screen, there was a survey that we had to take initially, and it basically gave you a score in the different areas of emotional intelligence. And then it broke it down into areas that you needed to work on, that you were good at, and it gave you feedback like that. So the next slide that I have is an example of what you would see if you took the quiz from the book that I discussed. And you can see that it gives you a score for each section of it. And then on the bottom left, which is probably really tiny to see, but it correlates to an area of where your lowest score was, and that correlates to a chapter in the book that can give you advice or strategies further to work on. So you can see on the top, there's different scores for each category. If you look at those scores specifically, this is basically how you can interpret them. So based on where your score falls, it can be something that it's an area that you need to work on, or it's a strength that you need to capitalize based on this one survey. Obviously, this one survey is not the end all be all, but it's a tool that we can use to help the amount of burnout and stress that we're feeling. Something else that I wanted to look at was how faculty and staff can better help providers or residents in programs. So the first one is scheduled check-ins. So scheduled check-ins can be used to develop personalized plans and optimize self-care and work-life balance. This will take additional time from everybody in the mix, but it's also useful in helping everybody make sure that you're on the same page and you're where you need to be. Going along with that is finding time to debrief and provide other resources. And lastly, organizational interventions. So this would be much bigger picture, but this would be looking at like the workflow or the work environment itself. So improving teamwork, improving workflow, and organizational restructuring. So this would be more costly and time consuming, but it can be more efficient in the long run regarding the relationship and retention of physicians and staff when talking about patient care. Just a bunch of different resources that can help as well. So the first one that I wanted to talk about was Silver Cloud. So it's an online behavioral health program designed to meet the needs of employees by delivering evidence-based education and tools based on cognitive behavioral therapy. And it can help you work with stress, anxiety, depression, and work-life balance. The one in the top of the screen there, BetterHelp. It's also a mental health platform that provides online mental health services directly to clients. You can do online counseling, you can do therapy services, you can do video visits, chat, email, text, whatever kind of works better for you. This is one that I have personal experience with, and it was a lot easier to be able to send a message than sit down and try to find a specific time during the week with an already busy schedule to go somewhere else and sit down and talk. The other one I wanted to mention, it's called Headspace. So this is an app that you can also get on your phone, and it has meditation and self-calming strategies. And you can set a reminder in there, like if you want to get on course, you can basically set it so every time at 7 p.m. every day, you want to run through and you want to be able to go through a guided meditation or calming strategy. Going along with that is one that is literally called Calm. So this helps you with meditation, guided meditations, and it also has sleep stories. So if you're a person that your mind's racing at the end of the night, thinking of everything that you didn't do throughout the day, or wondering if you locked your back door, like I wonder every single night before I go to bed, this can help you kind of calm your mind and eventually fall to sleep. MoodFit in the middle there, it's a free app that can help you track your mood and provide resources on managing negative emotions that you're experiencing. This one has the structure of a fitness app, so if you're somebody that likes the tracking abilities of that, this might work better for you. Happify is a free app that's also available that can also help you with anxiety and depression, and it helps with like coping strategies, pretty similar to the other ones as well. And the last one that I want to put on there is one of the most well-known depression resources, which is the National Suicide Prevention Lifeline. So if it ever gets to the point where it's super bad, there is somebody that can always talk. There is somebody that's always by your side, and you can use these resources as you need to. So overall, I just wanted to sum it up and say that it is a common thing among burnout is a common thing among different specialties, residents, depending on whatever area you work in, but there are ways that you can manage it either by yourself, with the help of therapists, with other faculty, and you can get through it at the end of the day. So those are my references. And then lastly, any questions from my presentation?
If you have any questions right now, please feel free to unmute yourself or type into the chat. If there are none right now, we can move on to Dr. McEliece, and you can ask your questions later. Right.
Hello, my name is Lokay McEliece, and I'm here to talk about does lifting style increase your injury risk? The objectives I want to hope to accomplish today are to discuss the forces through the spine in a biomechanical model, examine correlations between spine position and lumbar spine forces, identify pros and cons of different lifting styles, review literature regarding the best lifting technique, identify risk factors for the development of back pain and injuries while lifting, and examine prescription. Now, the problem at hand is that low back pain is the leading cause of disability globally. There's a well-documented risk factor for the development and exacerbation of back pain. Injuries and pain are generally attributed to mechanical loading and overload lifting, so much so that around 1/3 of all work-related injuries involve the lumbar spine. There are profound impacts to people's personal lives, with millions of disability-adjusted life years lost. In addition to the personal impact, there's a large societal burden, with billions of dollars spent on back pain and workers' compensation alone. With that in mind, I want to show you a series of pictures. With the first series, I want you to imagine this person is picking up a key ring. Are there any positions you would not recommend? Would your recommendation change if the person had back pain? In the second series, I want you to imagine this person is lifting up a box they perceive as heavy, but it's still liftable. Are there any positions you would recommend for? Would it change if this person had back pain? So just to see how your recommendations stack up to the current recommendation advocates to keep a straight back and to lift with your legs. To perform a proper lift, you want to position yourself as close to the object as possible and directly face it. You're going to bend from the knees, keeping an upright torso, and squat down to grab the object. If you don't have the ankle mobility to do this, it's okay to go up onto your toes, but during the active lift, be sure to keep your torso as vertical as possible and let your legs do the work. These recommendations are largely based on biomechanical models. A large portion of the literature has been directed at the L5-S1 junction, with the thought being that the forces experienced at this segment would be the largest. After all, this is where a majority of disc herniations and pars fractures occur. However, these forces will occur at every level of the spinal column and will be influenced by the pull and co-contraction of musculature, passive stability of ligaments, intra-abdominal pressure, and positioning of the object, trunk, and spine. The general idea is the more you flex your spine, the more internal shear and compression you develop, the more you stress your injury. As a brief review, compression is an axial stress when force acts perpendicularly to the surface of an object. In the lumbar spine, compression is largely generated by the muscular pull of segmental and global musculature, and secondarily created by axial loading. This type of force has been linked to bony failure, end plate fractures, and the aptly named compression fracture. Shear, on the other hand, is a force that acts parallel to the surface of the object. This type of force results in pull in one direction and an opposite pull in the other. While there is anterior and posterior shear, most of the literature describes anterior shear as being the biggest risk factor. So if we grab something in front of us, there will be an anterior shear created. Slow motion shearing is linked to ligamentous avulsion fractures, and higher speed shear is associated with ligament tears. All types of shear place stress on the facet joints and on the neural arch. And then lastly, our moments experienced in the lumbar spine. A moment is the perpendicular distance from the point of rotation to the force's line of action. In more simple words, forces located further away from where movement is occurring result in greater moments. As an example, the moment at L5-S1 would be the same if you held a 20-kilogram load at arm's length and a 40-kilogram load held directly between the knees. Now, there's different types of mechanical overload that can occur that predispose from a high magnitude force applied briefly, like a motor vehicle accident, medium trauma, repeated, like with lifting and repetitive tasks, or a sustained low load force, like postures. This presentation focus on lifting will be more along the lines of talking at the medium forces that have been repeated. In order to better understand these repeated forces and how tissue responds to it, various authors have created studies involving cadaveric tissue. One of the more prominent experiments to observe injuries involved fixing a cadaveric motion segment into a jig, as seen in this picture, and then they flexed and extended this tissue through a range of motion incorporating twists and compressive forces. This line of research found that at a moderate to light load, only 86 kilograms, paired with 70,000 cycles of flexion, caused posterior disc herniations, and with increasing weight, caused end plate failure. Authors have taken this information and concluded that injuries, especially disc tears, occur over time, and while it may feel like isolated movements account for these injuries, in reality, it's the repetitive loading that causes microtrauma, eventually building to tissue failure. While this is the most commonly cited study of this type, it is not the only study to do this. Authors have done this with varying degrees of flexion, rotation, compression, movement frequency, as it does show damage builds over time, even when trying to simulate things like running, which is interesting considering more recent evidence shows that running is associated with increased disc height. Now, there's a significant difference between cadaveric tissue and living tissue. One of the criticisms is that cadaveric tissue does not adapt and it is substantially less resilient than that of living tissue. Cadaveric tissue shows that the thoracolumbar column as a whole can only withstand 60 newtons of force before collapsing. However, in living tissue, powerlifters can experience up to 18,000 newtons of compressive force and be fine. So when examining forces in people, there's a lot of options for movement. However, a bulk of the literature is focused on polar ends of the spectrum, like stoop lifting with the knees straight and your spine flexed, and squat lifting, your knees bent and your back straight. When we start comparing forces in the lumbar spine, things seem pretty straightforward. Many studies found greater compression, shear, and net moments across the board with stoop lifting compared to squat lifting. This type of motion also incurs more stress on passive ligamentous structures, contributing to creep and long-term tissue deformation, weakening passive stabilizers. This, paired with the larger ranges of motion, build the argument that lifting with a flexed spine is less safe than a neutral spine. However, there are multiple studies showing a complete reversal of force profiles, showing higher levels of compression, shear, and overall moments with squat lifting. The higher compression in the squat is something that is seen pretty regularly, as the muscular pull is the greatest contributor to internal compression, and extended postures make the lumbar extensors work significantly harder. Now, there's a lot of things that are going to influence internal forces and movement, like the distance of the person to the object dimensions, weight, energy costs to pick something up, and of course, the ranges of motion required for the task. One of the main criticisms of the squat is that it isn't good for large objects or low-lying objects. And even though this change in vertical and horizontal distance is what accounts for the greater stresses seen in the previous studies. Even though there is less stress with stoop lifting in certain positions, authors have argued that there's still a better alternative to move. So this study asked the question, how do you lift a box that's too big to fit between your legs? Now, with the object started closer to the body, seen with the yellow bars, there's more compression, but overall, less shear. Now, if we ignore this yellow bar and we focus on stoop lifting, freestyle, and squat lifting, it seems like the overall forces, whether shear, compression, or total reaction forces are largely the same. So if the forces are largely the same between these movements, what is the difference between the lifting styles? Squat postures are associated with increased muscular demand of the quadriceps, upper and lower erector spinae, multifidi, trapezius, and deltoids. The higher muscular demand is due to larger ranges of motion required for this style of lifting. Despite these greater muscular demands and activation, they actually don't develop as much force or power as flex postures. Not because of the high energy demand and low force output of squatting, flex postures are actually more efficient and can allow people to lift greater loads and help stave off fatigue during repetitive tasks. At the end of the day, one of the major arguments is that this is the repetitive flexion and extension cycles paired with the internal forces that are responsible for this microtrauma. The ranges of motion vary depending on what the paper you read and the method they utilize to calculate overall motion, but stoop lifting is responsible for more lumbar flexion than squatting. However, it's important to point out that the lumbar spine still flexes during squat lifting. If it flexes in laboratory environments when people are heavily cued to maintain a lordotic position, it likely flexes more. To recap, The squat lift has a high mobility and energy tax compared to stoop lifting for the ankle, knee, and hip. The only location where more motion occurs is in the lumbar spine. And despite this increased motion, flexion doesn't appear to influence moments, shear, or compression. While the methods of the study I looked at utilize external sensors to calculate these loads, similar phenomena are seen with intradiscal compression. At this point, I feel like I have simultaneously spent too much and not enough time on this issue. Biomechanics have their place, but these studies have their limitations. There's an overwhelming amount of variables to control for, and modifying one can have profound implications on the others. Each study has different ways of measuring internal forces, measuring motion, calculating spinal loads, and these measurement models have varying degrees of validity, and each one can give potentially different results. Additionally, most of the literature focuses on extreme or squatting. Even when literature talks about freestyle lifting, there are constraints regarding starting and ending position influencing the overall movement. Real-world movement does not occur in a lab setting, and it's estimated that 80% of all lifting tasks occur in awkward positions due to the situation, environmental issues, or awkward shapes and sizes of the objects. Now, regardless of the study I've cited in this previous section, recommendations based off of their findings, ranging from advocating for freestyle lifting, stoop lifting, or squatting. So to take the biomechanical analysis out of our minds, let's shift to real-world examples of how movement styles can impact pain and injury. In 2020, these authors performed a literature review to determine if lumbar spine flexion was a risk factor for onset and prevalence of back pain. Overall, they found low-quality evidence showing a link between lifting position and pain. Now, it's not that there is no evidence, it's just that it is incredibly low due to poor research methods, like using a wide variety of measurements with varying validity, small sample sizes, lifting light loads, only examining sagittal forces, performing poorly described populations, poor differentiation between spine and trunk flexion, poor descriptions of back pain, and few studies discussed power calculation and statistical analysis. They discussed that lifting frequency and intensity are correlated, especially when doing more than 25 lifts per day or when lifting loads are greater than 25 kilograms. This suggests that it might be the dose that gets people, but the position isn't necessarily a risk factor. And while I'm focusing on this author, there are multiple studies supporting these findings from both biomechanic and ergonomic literature. There is overall no consensus regarding spine position or lifting style and injury risk. However, in an attempt to improve the clarity of evidence and rectify some of the issues found in that review, this study focused on material handlers, people who lift things for a living. Participants had more than 5 years of workplace lifting experience and performed a minimum of 25 lifts per day. Half the participants had a history of low back pain within the last year, and the other half did not have back pain within the last 5 years. Low back pain was described as pain between T12 and the gluteal fold, lasting for greater than 3 months in duration. Lifting had to be an aggravating factor, and their pain was greater than 3 out of 10. Because of their pain, they either missed work, took medications, sought assistance from a healthcare provider, or had to modify work-related duties. Participants performed 100 lifts, including symmetric and asymmetric tasks, and the weight was determined by taking 10% of the participant's body mass. It was still a fairly light weight. They collected range of motion data using intralumbar flexion and collected data on 21 biomechanical points, monitoring fatigue, heart rate, and Borg RPE scales, and then pain with NPRS. What they found was that all participants flexed more over time. Workers with a history of back pain initially started with a more squat-like and neutral posture, but their form changed over time, increasing motion by about 4.5 degrees. However, flexion never reached the same value as people who did not have back pain. People with low back pain also had higher intralumbar flexion variability in their peak ranges of motion, which may relate to changes in proprioception and co-contraction, as was seen with other studies. Now, workers without back pain flexed more over time as well, but only by about half as much. They showed far less movement variety compared to the low back pain group, and also utilized around 90% of their maximum available intralumbar flexion. And this intralumbar flexion is something that's seen as largely normal and even some powerlifters maintain a spine position only 2 to 3 degrees away from maximal lumbar flexion. Now, the group with low back pain built considerably more fatigue during the test than the group without back pain. Despite these differences in fatigue, there was actually not a difference between heart rates in these groups. This means that the group with back pain, the fatigue rating didn't have a correlation with heart rate, suggesting that perceptions of fatigue are more influenced by other factors. The fatigue experience also has a relationship to the pain developed. On average, there was a 2.2 increase in NPRS scores. 2 participants did not experience an increase, and 1 even had a decrease. None of the 21 biomechanic factors had a correlation with pain ramp, including flexion. Now, the absent correlation with flexion and pain ramp brings up an interesting idea as to why do people with low back pain flex less? Is it a feeling like we need to protect the area? Is it something we naturally do? Or is it related to the information we give about people in order to protect an injury? So far, we have a problem with the current recommendations. We're trying to put a single recommendation to a multifactorial problem. The importance of lifting and posture has been stressed since before Cyriax wrote about lumbago in the 1940s, and we keep pushing the idea, even though there are issues with cadaveric studies, force profiles, and little or weak real-world evidence demonstrating a link between the two. While there's a growing body of research showing these issues, these have been pointed out since the 1980s in both the NIOSH lifting guidelines and by McGill, the guy that I talked about initially who flexed the cadaver spines. Almost every study I've mentioned or referenced thus far has admitted this problem and used it as a call for more investigation. And I agree, we need more high-quality studies, especially studies looking at heavier loads. Now, despite the variability in literature, lack of in vivo evidence, we just keep pushing the outdated recommendations. And pushing this doesn't really seem to be helping, and in fact, it may be doing harm. We know that there is a large psychosocial component to pain. Fear, worry, and catastrophizing are more well-documented risk factors for low back pain and disability. Continuing to say that neutral spine postures and squat styles are safer perpetuates these fears. This can result in decreased motion, protective movement strategies, and harm self-efficacy. Perceptions of not doing a task well or engaging in a dangerous task further reduces self-efficacy, creating fear-avoidant behaviors, and can lower overall fitness. Now, to put in perception of how widespread the idea is that we need to lift with a flat back, 90% of surveyed New Zealanders believe that lifting without bending their knees was bad for their back. So revisiting the first scenario, what did you pick at the start? What would you say now? How do your results stack up to the participants of this study? The bars on the graph show which postures you would not recommend. Larger bars mean that more people said to avoid this posture, and smaller bars mean that this posture should not be avoided. There is almost unanimous support for the squat posture, photo 6. There is more agreement on kneeling postures or mostly neutral postures like pictures 3, 7, and 8. However, I think it's incredible to see the agreement against positions 1, 2, 4, and 5. Now, overall, 77% of the therapists participating in the studies postures were unsafe. But how about this study? What were your recommendations then, and what would they be now? Now, this study asked, which posture would you recommend? So in contrast to the prior study, only 20% of respondents picked some form of rounded posture. The differences could be from a variety of reasons, like culture, experience, background, but one of the differences is surrounding weight. We went from a 70% realization that no postures were dangerous to 80% recommending against it. Physical therapists, nurses, physicians all give recommendations about how people should lift, and many people report that their ideas about lifting come directly from their healthcare provider. Generally, physicians and medical students hold more biomedical and biomechanical beliefs and tend to follow the classic recommendations. But we fall back on biomechanical roles at certain points. Now, our roles are of particular interest because physical therapists work with people on movement-related problems, and low back pain is the most common reason to visit a physical therapist. So there's potentially a deeper interaction between our beliefs and a patient's rehabilitation. To examine this interaction, this blinded, cluster, randomized cross-sectional study involved two groups of participants, both examiners and lifters. The examiner group was divided by kinesiophobic beliefs, and the lifter group was randomly allocated to one of two testers to determine the effects of beliefs on lifting performance. They performed a progressive lifting test, and the test was either terminated when the participant wanted to, the participant reached 85% of their maximum heart rate, or the examiner ended this session either due to safety or because they believed the person could not lift more. Overall, kinesiophobic examiners resulted in decreased lifting capacity of all participants. When paired with kinesiophobic participants, they lifted 14.4 kilograms less, and even with non-kinesiophobic participants, they lifted 8 kilograms less. The reduction in load can result in chronic underloading of tissue and sending messages that heavier lifting is not safe. Now, I'm not saying just flex people. I'm not saying have people do things even when they aggravate symptoms. Positions and different motions can be bothersome. When performing rehabilitation, the approach should be tailored for the individual's needs, wants, symptom irritability, aggravating and alleviating factors, symptom stability, deficits, and pain phenotype. With nociceptive dominant pain, there's tissue that's agitated. Should calm the symptoms down first, and then address areas of need like motor control, energy, power, or mobility. If people need to lift while they still have acute pain, you can experiment with different strategies to improve comfort and reduce overall disability. If someone has a nociplastic pain phenotype, we should look to implement graded activity, considering spine flexion and lifting are common sources of fear and pain, and graded activity has been shown to improve self-efficacy, reduce catastrophization, and reduce fear. There's an excellent mixed method study involving the use of education, relaxation strategies, and unloaded postures to help reduce pain, stiffness, and fear. And one of the more qualitative reports from the study is that it gave people's lives back, like they didn't need to protect themselves. So how do we prevent future occurrences of back pain? Repeated stress can harm us, but it's also what drives adaptation. This is why the best evidence for prevention is for people to engage in recreational exercise and perform resistance training. Even when people do heavier work, they need to continue exercise. And during exercise, we shouldn't necessarily prescribe a posture unless they have a problem, like they have pain or they don't have ability to change how they are moving. For the most part, it's okay to just let people lift. In addition to strength training, we can encourage a greater movement variety to help people find the best methods for them to fit the varying tasks they might run into. Now, this could be stooping, squatting, lunging, semi-stoop, semi-squat, kneeling. There's a lot of options for movement. But in other words, oh boy. Okay. Thank you for your attention. These are my references. And then what questions do you have for me?
If you have any questions, please feel free to either unmute yourself and speak or type it into the chat. All right, I do have a question. I have a question for Dr. Lokay first. You had mentioned that there's a lot of resources. Do you have any inkling or idea of what are the biggest barriers to using those resources?
The biggest barrier that came across in a lot of things that I looked at was time, and actually accessing the resources. So that's why I wanted to put in there some that they were kind of on your own time that you could do. That way you could use it for yourself, instead of having to make like a specific appointment time and then have to change work schedule or out of work schedule to go along with that. But it was mostly like the accessibility and the time management of it. Thank you.
Not saying to just flex on everybody. You're also not saying that you have to do it a certain way. You also mentioned unless there's certain specific restrictions. You didn't say, but do you mean like post-operatively, or do you mean like a specific pathology, or do you mean something else?
So I had meant something else, but post-operatively or with a an underlying pathology would or may influence how somebody's lifting. However, I was more along the lines of speaking if they could not break out, somebody could only flex to pick something up, that might have a problem, might not, but it's something that's worthy of delving into a little.
What would your specific recommendation be when instructing a patient with non-specific chronic low back pain on lifting? And would it vary from patient to patient? And if so, why?
So I think it would absolutely vary depending on the patient. There's no, that there can't be a one size fits all model for doing something like this. It depends heavily on what they present with and how they move. A general starting place where I go for is to try to utilize external cueing to get into I guess a comfortable position, and then tweaking it depending on how they respond to it.
Thank you. If anybody else has any questions, please feel free to type them in, unmute yourself, or email either Dr. McEliece or Dr. Lokay your questions. Thank you very much for attending. And again, please make sure you complete not only the quiz, but also the course evaluation so you can get CE or CME credit. And we will see you next month. Thank you.